You are watching a recording of a training webinar about how to conduct a systematic review. This webinar series was developed by the Impact Research Programme in partnership with Cochrane Common Mental Disorders and Cochrane Global Mental Health.
Welcome to session 2 of the Impact Systematic Review training webinars. It's really great to see so many of you again here, so welcome everybody. So I'm Jen Brown. I will be leading the session again today, and we'll just start off with a quick run through of what's coming up today. Bulk of the session will really focus on the review question and what PICOS means. If you don't know what PICOS means at this point, don't worry, because that's the whole point of today, that you'll know after the session what PICOS is about. We'll spend a little bit of time talking about what to include in the background of a review, a protocol, and the review itself, and then we'll also cover a little bit about the PRISMA guidelines. Again, if you don't know what PRISMA is, don't worry, hopefully you will know by the end of today. And we'll finish off with some homework for next time, and like last time, if we don't get through everything, we'll just roll it over to the next session, because we will finish on time. That's my promise to you. I'm a research fellow in the Mental Health and Addiction Research Group at the University of York, and my background is in systematic reviews and systematic review training. And yeah, so I'll be facilitating today. And let's get started with a quick welcome of the other facilitators. So we've got Najma today as well, and Nikki again for admin support. So Najma, do you just want to say a couple of words about yourself?
Hey, yeah, hello everyone. I'm Najma Siddiqui. I'm a psychiatrist and a senior lecturer at the University of York, and my research is on mental and physical health multimorbidity, which is why a lot of the examples we'll be using will be on those topics.
It was quite a vague sort of task that we'd set you, because we wanted you to really just have a browse of some websites and familiarize yourselves with different kinds of systematic review protocols. So we put some examples on the Google Drive, so if you haven't checked those out, do go and have a look at those. And the instructions are actually on the Google Drive as well, so if you do want to click through what we kind of suggested, then please, feel free to do that. Just put down some thoughts about what you've noticed looking at those different kinds of systematic review protocols. And if you only had a chance to look at one or two of them, obviously don't worry. Just put down some thoughts, and Najma and I will go through the chat and pick out some of the most important points there, and I will summarize those again in the slides before we share them. And I'll also stop screen sharing for this now, and then Najma and I will just have a little bit of a discussion of what you guys bring up in the chat.
So the question was about some of the differences you spotted, and then Pfizer has put something very important, which is that Cochrane gave more detail on background on the topic, whereas Prospero just was very specific in methods. And the BMC protocols also included a discussion section that wasn't present in the other two versions. So you can see all three are very different in the requirements that they have.
Yeah, somebody said Prospero protocol was easy compared to Cochrane, and yeah, I think Prospero is a lot more concise and a lot more very much focused on processes and methods with a lot less detail. So yeah, somebody else just saying that Cochrane is more detailed in the protocol compared with others, and that I would definitely second that.
I think the word
I got lost in the middle of reading in Cochrane. Yeah, that happens. That's quite normal.
I think the absence of a background in Prospero, I think they only allow you a few lines, that there is a word limit, so you can't really put very much in. But that does mean that when you come to actually writing up, it's much more difficult because you haven't done that. Someone saying that the register, you could register a protocol in Prospero Cochrane, but not in BMC. I think the difference is that, you know, well, with Prospero, it's a registration of the protocol. You can still cite it, but it's not quite the same as a peer-reviewed academic article, whereas a Cochrane protocol and the BMC publication would count as, you know, peer-reviewed academic outputs.
Yeah, and I will actually cover some of the key differences just in a minute anyway. And more support from Cochrane in review writing, yeah, that's absolutely true as well. Obviously, you know, once you're sort of on that Cochrane track, where you've registered a title, then you're doing your protocol, and then you're kind of in that pipeline and in that infrastructure to get that review finalized. There is a lot of support there that you wouldn't get on any of the other routes. So that's a very, very useful observation. One of the key points, I think, is that Prospero is not peer reviewed, and you have that chance to make amendments to your protocol on the website. So there is a permanent record of all the different versions. In a Cochrane protocol, but also in a published protocol, you wouldn't usually make those amendments. You would report them in the final review publication. Cochrane and other publications are peer reviewed. That takes longer. And especially with other publications, I think quite often in reality, you find that the review is quite far underway by the time that the protocol is published. Whereas with Prospero, you obviously have a requirement of where you are allowed to be in the review process when you register. So I think, in summary, I would consider for a review that you're conducting outside of Cochrane, I would consider Prospero registration an absolute must. That's something that you definitely should be doing. And then the publication of the protocol is very much optional and will depend on a number of things, like whether you've got the time, whether you've got the money to pay the open access fee and that kind of thing. But you need to keep in mind that when you get to publishing your review, you usually need to have a Prospero registration. For most sort of, you know, reputable high impact factor journals, they won't publish systematic reviews in health with health outcomes anyway if you don't have that Prospero registration. So Prospero has become such an integral part of this process that I think that should be considered mandatory really at this time now. I would like to sort of draw a line under the protocol topic for now. If there are any burning questions, you know, by all means do put them in the chat, and we will pick them up as we go through. And then there's just one quick question here that I'll pick up. Can we publish in BMC if registered in Prospero? Yes, absolutely, because I think there is recognition that a registration is not the same as a publication. So it's not a matter of, you know, dual publications. It is just different. And I think actually BMC systematic reviews does have a requirement for review protocols to be registered before they can be published. So keep the questions coming, and I will pick them up and put them in a summary document again. And I will start sharing the slides again, and then we can crack on with the rest of the session and focusing a little more on the review question.
I think whilst you do that, just to say that a lot of the other questions that are coming in, you are going to be covering anyway, so rest assured you'll get the answers.
That's really good. Right, so you might remember this lovely little optimistic arrow from last time. It's a very simplified overview of the systematic review process. In reality, it goes up and down and round corners, and, you know, is nowhere near as linear and streamlined as this. But for the purposes of teaching, I think it is a useful visualization to keep in mind. And as you can see, the review question and the protocol sort of share that first box. And that means that, you know, they are the foundations that the rest of the review is built on. The review question is a critical component of your protocol, and it informs the entire review, and your methods, your outputs, and everything that you're doing. So it is important to get this right, which is why we're spending a whole session on this. So where do review questions come from? How does this happen? So sometimes review questions come from your own ideas or your own research area. There might be things that are very obvious, gaps in the literature that can either be identified by your own previous work or by other people's previous work. Often systematic reviews contribute to finding those gaps. But it can also sort of be the other way around. In you're applying for a commissioned funding call, for example, where you're getting a brief and a funder tells you what they would like you to research. They are often very vague. And also, if you're working, in a priority area, there are several bodies now that identify research priorities. You will still only have a sort of rough area, or a broad area. Everything is quite vague, and that doesn't really work very well in the context of a systematic review. The problem sort of lies in the name there. So you need to somehow turn that idea or that brief into a review question that you can answer through the methodology of a systematic review. Now, to do that, you sort of need to consider what your review question needs to be. And that first point seems a bit silly almost, doesn't it? It needs to be the right question. And by that, I mean that there's no point, wasting energy and funding and time in answering questions that aren't relevant. So do spend the time of speaking with stakeholders, bringing PPI to play a role, so patient-public involvement where you can, maybe co-producing your review question with those people to make sure that you have something that is actually relevant and that will get the attention that your research deserves. Drawing on clinical expertise obviously is always crucial in systematic reviewing so that you can produce something again that is relevant and will be used. And the other thing that your research question needs to be above everything else is that it needs to be tailored to your methods. So you can't ask a review question, for example, about cancer screening accuracy if you haven't got the means or the expertise on your team to conduct a prognostic or diagnostic test accuracy review. And quite often systematic reviews come up with "we don't know" type of answers because the evidence isn't good enough, or there isn't enough evidence to really draw firm conclusions. But that's fine, because that is a finding in itself, and that can, like I was saying, often these reviews point out where there are issues, or where there are gaps rather in the literature that need to be filled maybe by primary research in the first instance that can then be synthesized further down the line. And in terms of what we're going to be talking about in this session, your review question needs to be well defined, and what that means is what we're going to unpack in the next couple of slides. I will be flicking back and forth between sort of general transferable points about this and coming back to an example that I worked on a couple of years ago, working with a neonatologist. And one of the clinical questions that he faced on a regular basis was how much oxygen to use to resuscitate babies, preterm babies, after birth. So, this is the kind of thing where, you've got a question, it's sort of in your topic area, maybe that there isn't really a consensus about this in the literature. So it's a kind of a classic example of how you, of what makes you want to do a systematic review. And I think, on first glance, this already looks quite concise. I mean, it's a line and a half, it's, sort of scientific academic language. And, maybe we can set off and do a systematic review straight away. But I will hopefully convince you over the next couple of slides that that's not the case, that really those 2 lines there is very vague, and it would be a complete disaster if we tried to do a systematic review with that as our review question. I'm pointing that way because I can see my slides on the screen here, so don't, no, it makes no sense to you, but there you go. So for example, I wonder how much oxygen is best to use to resuscitate preterm babies after birth. What does how much mean? What is the intervention? So thinking about components of our review question, what is the intervention that we're interested in? And how are we defining this notion of how much oxygen? Thinking about outcomes, we're saying here, I wonder how much oxygen is best to use. Again, what does that mean? Are we interested only in positive outcomes? Are we also interested in negative outcomes or, adverse events? I mean, how will best be measured? Is this about survival? Is it about illness? Is it about what's best for the baby, what's best for the parents? So we need to think about what outcomes we're interested in for this systematic review. And then lastly, we also need to be very clear about who these preterm babies are. What is preterm and what does after birth mean? Does that mean immediately after birth, or does it mean when they're on the neonatal unit? Or, it's after birth now for all of us, but, that's probably not what is meant here. But this kind of level of detail is what you need to think about when you're trying to define your population, as well as all the other components of your review question. And they have helpfully been arranged in a neat little acronym, PICOS. So the components of the review question are population, intervention, comparator, outcomes, and study design. Sometimes the S is dropped, so don't be alarmed if people just talk about PICO, because often, the study design is not as important. But we will, for the sake of completeness, we will cover all 5 today. Work through these in order now, like I said, going back and forth sort of between general information and coming back to this example with the preterm babies. So this is also a good point to remind you all that the focus of this webinar series is on intervention reviews. The PICOS acronym does not translate directly to other types of reviews, such as diagnostic or prognostic reviews. But the need to clearly define your review question applies to all types of reviews across the board. There are some other kind of acronyms or frameworks that you can use for other review types, but we will focus on PICOS here. And this is, what I was meaning about transferable skills. This sort of detailed thinking is something that you need to do regardless of what kind of review you're doing. However, you do also need to keep in mind that you want to strike a balance between finding clear and unambiguous definitions and being so narrow that you exclude relevant evidence. So there is a balance to be struck here about maybe accepting that there might not be enough evidence that can answer your exact specific question. So you need to be aware of the area enough to be able to acknowledge, for example, if there are related populations, for example, or related treatments or conditions where you can borrow evidence from that can inform your review. So we will start with the P in PICOS, the population. So your population can be specified in terms of a clinical group. So that could be something like people with diabetes. It could be a social group, such as women over 50. You could define your population by setting. So that could be primary care, it could be schools, it could be prisons. It could also be geographically defined. And age and gender are usually, key information that you need to get defined for your population. So for age, it's a lot more straightforward to use age ranges, so under 18s or 13 to 19 or over 65. That's a lot clearer than using ambiguous terms like children or young adults or the elderly, because they are so open to interpretation, and they will vary massively, not just between countries and sort of research areas, but even between the people in your team. When does a newborn stop being a newborn, and then does it become a baby or an infant, and when does it, is there such a thing as toddlers, or are they just children? So you get the idea. Using age ranges just sort of gets rid of all that sort of wooliness and ambiguity. So go with numbers. They just make it a lot clearer who you're interested in. You can, at this point, you do sort of, coming back to this point that I was making earlier about not wanting to exclude relevant evidence, you can think about generalizability here as well. So can the studies from a different patient group be used to inform the evidence for your chosen group of interest? Also think about what about different geographical settings, and whether or not evidence from high income countries can be translated to low and middle income countries, or if really the differences are so fundamental that they require looking at separately. At this point, you might want to consider input from key representatives such as charities or patient groups. So if you know, for example, that your clinical group of interest is people with diabetes, it might help to have somebody on your team who is, part of a diabetes charity group or something like that, if you have the means and the resources to make contact with these kinds of groups and engage with these people.
Can I, Jen, just add that I think the really key trick here is to understand when you can group things together and when you actually have to split them. So, if you're saying that we can accept evidence from one part of the world, it's actually going to be very similar to another part of the world, then you wouldn't split. Then there's no need to exclude based on geographical setting. So for example, if you've got a drug and you're thinking human beings all over the world are pretty similar, and we're only looking at that kind of, the pharmacological effects, well, then would you say that someone in Asia is going to respond differently from someone in Europe? You might still think actually different ethnic groups may have a different response. So you might then think, okay, I do need to focus, on a particular ethnic group. But those are the kind of questions you have to ask. And you're trying to be broad as well as specific and get the right level. And that requires knowledge. Sometimes it's clinical knowledge, sometimes it's just knowledge about cultures. And that's why it's really important to involve patient groups or clinicians if your question is clinical.
Yeah, thanks, Najma. I think you're raising really good points there, and in a way this is where systematic review training becomes a little bit frustrating, because quite often we can't actually give you the answers for your specific review topics or your areas of interest, because it's so dependent, like Najma was just saying, on that specific knowledge that you hopefully will be able to access. So we're just basically, prompting you here to think along these lines and giving you some key points to keep in mind, without actually being able to provide you a tick list as in how to define a population. So thank you for coming in there, Najma. Really, really good to get that additional information. So coming back to the oxygen example, we defined preterm babies, like I said in my sort of question. So preterm neonates were defined as any baby born at less than 37 weeks gestation, so born before 37 weeks of pregnancy, or with a birth weight of less than 2.5 kilos. These were pretty straightforward definitions because they're sort of generally accepted in the field. And the after birth thing we defined as receiving resuscitation in the delivery room, so immediately after birth, not when they're on the unit, not when they're on the ward, but right there and then. That was our population of interest. Going forward to the second letter, the I, for intervention. So again, this is the slide where I throw lots of thought, lots of prompts and hopefully thought-provoking ideas at you. So your intervention may be specified in terms of something that you want to treat or prevent. So it could be any kind of condition, say colon cancer, for example. Obviously, you will be looking at different outcomes depending on whether you choose a treatment or prevention kind of question. So that's something that you need to keep in mind, and this is where I was saying earlier, your review question influences all of your systematic review all the way through. Interventions can also be processes of care. So for example, early discharge from hospital following surgery, that's a process of care, but you could look at it in terms of it, you could conceptualize it as an intervention for the purposes of a systematic review. You might be looking at social or educational interventions on a sort of bigger level, you know, poster campaigns, TV adverts, keep washing your hands, you know, that kind of public health level. Often, you know, traditionally, I suppose, interventions would have been drugs or surgery techniques. When you're thinking about what exactly you're talking about at this point, you know, beware of drug brand names. Things are called different things in different areas of the world. And you can either be, you know, comparing established drugs and procedures, or you could compare a novel drug or a novel approach. And the other thing that you need to consider here as well is, are you interested in any pharmacological treatment compared with, say, a psychological comparator, or are you comparing different classes of the same kind of drug? So this is obviously, you know, highly relevant, for example, for antidepressants. Are you placing any restrictions on the intervention that you're interested in? So for example, are you only interested in low dosage of a certain drug, or are you considering all dosages? What about intensity? So how often are your CBT sessions being delivered? Does it matter how long your intervention is being given for? And also, does it matter who is delivering the intervention? So sometimes, you know, we compare peer counseling compared with counseling delivered by healthcare professionals, teachers, doctors, or nurses. So there's different things that you can consider here again, which will be, you know, very different depending on the area that you're working in. And coming into that, back to that knowledge point again that Najma just made, you do need to consider a little bit what happens in practice. So do speak to your clinical experts, but also speak to service users, just to find, you know, make sure that this is relevant. In the oxygen review, we defined the intervention as low oxygen concentration. So that was defined as 21 to 50% oxygen. And important to keep in mind here that ambient room air contains about 21% oxygen. So the cutoff of 50% was arbitrarily chosen by us as the review team, but we had to cut it off somewhere. We could have made it 55 or 49 or, you know, whatever, but 50 seemed relatively easy to conceptualize. And, you know, for all my talking about being systematic and transparent, sometimes you do just have to make these judgment calls, which is absolutely fine, as long as you're transparent and you report them in your protocol. Ideally, if you can't put it in the protocol, you definitely have to talk about it in the methods section of your review. So again, this is where the clinical knowledge and expertise comes in as important when you have to make those judgment calls. 3 out of 5 now, so the C in PICOS. The comparator. usually that's defined in a similar way to the intervention, which I guess, hopefully makes sense. It must be relevant and reasonable. So you want to, find a balance here between having the biggest review ever, comparing everything with everything else, using all realistic comparators, but it might just not be possible. And this is where this lumping and splitting thing comes in again. Is it really the best idea to write one giant review, or are you better off splitting it? Do you have the resources and expertise to include multiple comparisons in your review? And quite often, you will see that systematic reviews can either be, they compare an intervention to no intervention, or a placebo, an active comparator, or to current standard practice or treatment as usual. Again, this will massively depend on what area it is that you're working in and what your question is. Another important concept to keep in mind here is equipoise. So you wouldn't want to compare two treatments if you already know that one is superior and inferior. So you're sort of starting out from a point of not knowing and assuming that they might both be the same. And you're doing this research now to figure out whether or not one is in fact, one does in fact have, for example, is more effective than the other or not. And sometimes it's really helpful, again, at this point, to speak to your service users and clinicians, just in case there's anything that you or your team just didn't think of. Sometimes there are comparators that are maybe so novel that you didn't actually know about them. In the oxygen example, it was very straightforward, because if the intervention is low oxygen concentration, then the comparator is high oxygen concentration, which we had defined following on again from the intervention as more than 50%. Talking about outcomes, the O in PICOS. Often in healthcare research, obviously the outcomes are a health state. So is it, death or illness are often top of the list there, because that's the kind of things that we want to treat or prevent. And adverse events come into play here as well. Quality of life is often a key outcome, and health resource use, especially if you're sort of interested in comparing processes of care, do people, even if you discharge them early, do they just keep coming back to the hospital, or are they constantly phoning up their GP? Do they need to go to A&E all the time? Again, this will massively depend on your context and your question. Behavior change can also be a key outcome. Do people, if you were looking at a smoking cessation review, for example, is that smoking cessation maintained? Are people able to keep it up, or is it something that wears off again very quickly? And then you need to think about, how are these outcomes measured? Once you've defined your outcomes, is it a matter of counting cases of death or illness in each group, or is there a score? So for example, if your outcome is depression, how do you measure that? I don't even know how many depression questionnaires there are, but you need to think about that, and you need to think about if it matters. Are you only interested in depression measured by a certain questionnaire, or is it any definition of depression? Again, speak to your clinical experts to make sure that your definitions are relevant and appropriate, and also consider length of follow-up, especially if you're looking at adverse events. Sometimes follow-up needs to be a lot longer. Obviously, you're always a little bit, or you're massively restricted by what is reported in the primary studies. But if you're saying actually we're interested in long-term follow-up, then at least you're giving the chance for that data to be included. And co-production and speaking to stakeholders at this point is really key, because you want to ensure that the outcomes that you include are relevant to the service users. In our example, we had primary and secondary outcomes, which is very much a Cochrane thing, which we can maybe pick up again at a later point, or if you've got a burning question about it, I'll answer it offline, and we put it on the Google Drive. So our primary outcomes were all-cause mortality prior to hospital discharge, so basically babies dying in hospital. And then we had also specified that we would be interested in longer-term follow-up at 12 months and then at 5 years in terms of neurodevelopment, disability, and cognitive and educational outcomes. The secondary outcomes were more sort of biochemical and medical outcomes. So APGAR score, which is sort of a quick indication of the health of a baby when they're first born. We had specified some invasive procedures, so intubation, for example. Morbidity, again, where we had specified the conditions of interest, and then the duration of hospital stay. And finally, study design. So generally speaking, and again, the focus of these webinars is on RCTs, because when considering the effectiveness of an intervention, randomized controlled trials, or RCTs, are the most robust design. We will cover risk of bias in one of the later sessions, but that's generally accepted now, that to measure effectiveness, you really need to be looking at RCTs. However, that's not always possible. So for example, if you're looking at diagnostic or prognostic reviews or reviews of emergency care, I think we're all pretty pleased that, you know, nobody is randomizing people after a car crash or something, whether or not they're getting emergency care or not. So you need to be flexible in this, and I said earlier that not always is study design considered as part of the review question. And if you're interested in wider questions, such as implementation of complex interventions or the acceptability of an intervention, you might well be looking at qualitative data as well. But again, make sure that the question that you're asking matches your team's expertise and skill set. There's no point including all of this in a review question if you have no way of answering it. And in the example, we had specified that we would be including randomized controlled trials, quasi-randomized controlled trials, which we defined as so-called randomization by date or day of birth or hospital number. And again, we will come to the reasons why that doesn't count as real randomization when we speak about risk of bias, or cluster-randomized controlled trials where units are randomized to either intervention or control rather than individual babies. So we ended up in the end with the review question of what are benefits and harms of using lower versus higher oxygen concentration for delivery room stabilization of preterm neonates. And then you can see there it's published in PLOS One, and the title was Lower versus Higher Oxygen Concentration for Delivery Room Stabilization of Preterm Neonates Systematic Review. So your title obviously needs to be informative but readable. So you don't have to shove all the detail into your title, but you do need to be clear about what all of these terms mean. I've talked for a long time now, and I will open up the chat just for a couple of questions, because I think it's a good time to pause and think back over PICOS now. So I will stop screen sharing so I can see the chat a bit better, and then we can pick up some of the most burning issues.
Whilst people are putting things into the chat, I'm just going to pick up on some questions that have been coming through already. There seems to be a number of questions that are related to, can you do a systematic review that's a bit different? And I just wanted to make the point, we are actually talking about systematic reviews of trials here, you know, intervention studies. So the PICOS doesn't quite apply to the other types of review, and we won't have time in this series to go through all the other different types of reviews. And then people are asking, you know, if you can compare interventions at different time points. And again, I'd refer you back that you have to think about this, is can this be trial? So can you, you know, this is about intervention intervention A being compared with either intervention B or with a control. If you can do that kind of scenario, if that's your question that speaks to that scenario, that's the kind of systematic review we're talking about.
Do we primarily focus on primary outcomes for selection of a study and a review? What if not all the secondary? Yes. So the question is, what if not all the secondary outcomes were measured in the study? Do we still include it? The answer is absolutely yes, because it's an important finding to say, for example, we specified these really important outcomes that matter really, really strongly to parents, for example. But none of the studies report them, because none of the studies that we have found have long enough follow-up to include things like longer term effects of certain things. So I think that is a really good question, and the answer would be yes, absolutely do include those studies, because they give information that is relevant for further research. So
at the same time, I think, Faiza, you're right that we do focus, we do say, does the study include a primary outcome? And if it doesn't, then you have to pre-specify what you're going to do. I made a mistake quite early on. I did a review and I included studies that didn't include the primary outcome but did include some of the important secondary outcomes, and then got into quite a mess, because I wanted really I should have looked at primary outcome studies only that included primary outcome. It just made my review very big. That's why it was messy.
Yeah, so I would like to cover the couple of slides that we've got on what we need to put in a background. So I will stop the questions at this point and come back to them and write them up for you for the Google Drive. So I will start sharing the slides again and hand over to Najma now to just sort of talk a little bit about what needs to go into the background of a systematic review protocol.
Okay, I'm aware that time is quite short, but I did have a very quick poll first just to see check if people are happy to go ahead and go on to looking at the background, or you'd like us to go back over the PICOS. And very, very quickly, this is your chance. It's a democracy. So it's going to be, 50% is going to be the cutoff. If we get over 50% wanting to go ahead, I'll go ahead. Okay, it looks like, unless we have a late surge, yes, people are ready to go ahead. So apologies to the 8 people that weren't ready, but you will have a chance to continue to ask questions, and Jen's going to respond to some of the questions on the chat as well in between. Okay, so remember we're going through the components of the protocol, and one of the first things you read when you open up a protocol is the background. So I wanted to, I was going to ask people to perhaps put in the chat what they think needs to go into the background, but I'm just looking at the time and thinking we've got 7 minutes, so perhaps we should just plow ahead for now. So your background is, sorry, yeah.
Sorry, there we go.
Yeah. Your background is an introduction to your topic, to your review topic. This is your chance to tell people why it's important that you're doing this review, why you're doing it. And by now, having thought about the review question, you should actually know why you're doing this. And it's just a case of conveying it to the reader who hasn't been through your journey. And if you're thinking ahead about publication of this review, you need to convince a journal to publish this, so you need to convince them it's important. So why is it relevant? And why is it not just relevant? Why is it relevant now? Why is it important? Why is it timely? And to do that, you need to tell people also what's already known. We already know this much, but we don't know this. And that's why I'm doing this review now. And so you will need to have a really good understanding of the literature already before you do a systematic review. You'll need to know what other systematic reviews have been done already. why are you doing this one if there's already been one before? So, it could be that the other review's old. It could be that it covered a similar topic, but not quite the question you're interested in. So you need to put that into your background as well, just to show people that you have read the literature, you know what's there, and you have still identified a gap. So you're making that argument. You might find it helpful to use subheadings as you go through, and I would encourage you to go and look at some recent Cochrane reviews and see how they set out the headings. So they will help you go through and say what needs to be included. You need information about things like the intervention that you're going to be talking about, the focus of your review, the intervention. What is it? What is it used for? What's the likely mechanism of action? Jen said that you need to pick a question that addresses an important equipoise question, i.e. you don't know whether this intervention works or not. But you do, you don't just randomly start reviewing evidence for any old intervention. You need to have some justification for picking that intervention. Is, what are the likely mechanisms of action, for example? This population, why is this condition important for this particular population? How common is it? What's the burden of it? In this particular, if you're picking a particular geographical area, why is it important to focus on that area? And you need to put this information in a logical way that is easier to follow. So that's why I suggested the headings, subheadings. Okay. So each background will be different, each introduction will be different, but these are the main things that you want to emphasize in it. And that will lead you on to your question. So a good introduction should set you up nicely. So almost without writing it, the reader should be able to say what your aims and objectives are going to be at the end of the introduction. But you do specify them to make the link between the background and the method section. You will spell out your aims and objectives. Next slide, Jen, please. So here's an example of aims and objectives. As I said, in a way, this is almost self-written. I'm going to just leave it there for a couple of seconds rather than read it out. And as I said, these slides are going to be available because we promised to finish on time. And I just wanted to use the last 3 minutes to go over the homework. Jen, do you want to take over?
Yeah, that sounds sensible, Najma. Thank you. So, like Najma said, you will be able to read this back in your own time, but really this is just a highlighted slide where I've highlighted the PICO elements in these aims and objectives that are taken from a review, that a recent Cochrane review. So, the link, the reference at the bottom of the slide, go and check that out at your leisure. So we're going to drop talking about PRISMA. I will integrate that into the homework and we'll pick it up again next session. All of it is open access, so the website again is on the slides there, so do check that out and then we can discuss next time. So your homework for next time is building on what we've just talked about in terms of PICOS, and we will be asking you to think about the PICOS elements for an example review topic. That will all be emailed to you and will be available on the Google Drive again. And there will be many right answers because, like you will have hopefully picked out of the session today, none of this is necessarily that straightforward and ambiguous. So what we want to do again is to get you into this way of thinking about, these are the things that I need to define, and this is one of the ways that I could do that. Familiarize yourself with PRISMA and PRISMA-P. Again, all the details and resources that you need for that will be on the Google Drive and via email. So hopefully that will give us a really sort of good way to deepen your understanding of what we did today, and then next week or next time, rather, in a fortnight, we can pick up on those things again. And We will finish just with a reminder of what happens next. We will upload the slides, we will upload unanswered questions and share the homework with you. And we will also share the evaluation form for this session. So please complete those again so that we can continue delivering these sessions in the best way for you guys and making improvements where they're necessary. And Nikki will share Zoom details for next time. So our time is up, and I would like to thank everybody very, very much for joining again today.